All right, good evening, everyone, and welcome to AHIN Hour. Tonight's session is the first of this four-part openIMIS online training. We are extremely grateful to the openIMIS initiative, especially to our friends from GIZ and SwissTPH for giving this learning opportunity to the AHIN community. This session is made more interactive, so please carefully listen to the instructions of our resource persons. I will now hand over to Sir Sarav and Sir Siddharth to begin the training.
Hello, everyone. On behalf of the openIMIS community, I'd like to welcome everyone to the first in a series of webinars aimed at providing information on the openIMIS tool, as well as the business processes supported by it. We hope you are able to learn of the capabilities of the system and think of ways how such a system can support you in your systemic needs. Please feel free to reach out to us through our website, www.openimis.org, or our wiki, following the webinar to follow up on specific issues, or you can directly reach out to us as well. I'd especially like to thank the AHIN team for the organization of these sessions and hope to see you all in all the upcoming sessions in the days to come as well. With this, I'll hand it over to Siddharth, the health financing and openIMIS expert from the Swiss Tropical and Public Health Institute, to take it away. Thanks.
Thank you, Saurav. And hello, everyone. As Saurav mentioned, I'm Siddharth. I'm based at the Swiss Tropical Public Health Institute, based in Basel, Switzerland. And I'm working on a lot of health financing topics and specifically health insurance. So as Saurav mentioned, it's a series of sessions that we have, and we are trying to build one on the other. The first one, which we start with today, is really going to kind of set the scene a bit. And in the subsequent sessions, we are going to delve more deeper into openIMIS. So just in terms of kind of, what I try to do here today and what I would hope that you will take away from this session is really the understanding of some key health financing concepts, which provide a broader framework within which different health and financing interventions are fitting in. I will speak specifically about one of these interventions, health insurance, in terms of processes whose digitization needs are then covered by a solution like openIMIS. In your context, the broader concepts as well as the specific intervention of health insurance. And how we'll structure the session today is essentially in these two key blocks. The first part just focusing on health financing concepts, and the second one would be going specifically into transactions and processes within health insurance systems. How the session will be run, we basically have limited time and we wanted to make it a little bit interactive. So what we will do is I'll initially start with block one for about 10 odd minutes on the concepts that I mentioned. If there's any kind of questions you have, please do type it into the chat. We'll break at that point and try to answer some of these. And after that, we'll try to do some reflections in a virtual breakout session. So we'll split you into smaller groups and allow you some time to basically reflect on what we have discussed. And so that you're able to relate it with the next block, which I'll take around about 20 minutes or so to cover. And here again, please do type in your questions at any point if you have in the chat. And in the end, we'll try to wrap up with answering some of these questions. And as Saurav mentioned, if we are not able to answer all your questions, we'll try to document these and then share it with all of you at a later point. And also, just to remember, in block two, we are trying to make it a bit more interactive. So we'll do some small polls. We'll ask you to please keep an eye out then on these prompts which come to you. The polls will be opened and then closed. So would request you to please also respond to them. And once again, at any point, if there are any questions, please type them in the chat. So starting now with a broader context, we've got a healthcare system, and this is quite a common framework which is used nowadays and discussed by WHO, which is the whole system being structured around 6 key building blocks. And you have the service delivery, health workforce, health information systems, access to essential medicines, financing, leadership, governance. Some of these health information systems, leadership, governance are kind of also a bit cross-cutting. And also what we talk about is partly also falling in that category. But mainly what we want to what I want to at least talk about is really this financing block. And this essentially refers to the function of a health system concerned with primarily with mobilization, accumulation, and allocation of money in an equitable manner, of course, to cover the costs of healthcare needs of people. So it's essentially within that block that we are talking about different interventions, health financing interventions. And the purpose is really to make funding available as well, set the right financial incentives to providers to ensure that all individuals have access to effective healthcare as and when they need. So essentially, the understanding is that all these building blocks then contribute to these overall goals of improving healthcare, improving responsiveness, and of course, higher efficiency and social and financial risk protection. A lot of you must have seen this very commonly used so-called UHC cube. And in a lot of health financing strategies which are being created in different countries, you always have some kind of a reference towards this concept that everyone in a society, and that's everyone in the society is really able to obtain healthcare services that they need at a high level of quality and without any fear of financial hardships. So the drafting of the health financing strategies are generally around these um, key statements, which in this cube is essentially across these three dimensions. So really that any kind of strategy should really try to reach out to all the subsets of the population. So increasing the coverage on the population dimension, and then provide services. So the provision of services is really not just in terms of quantity, but also really quality. So higher quality services and try to offer as much as possible. And then of course, this dimension of financial protection. So trying to reduce out of pocket expenditure. So that's the expenditures that you do at the point of care. So reducing this cost sharing and fees. In any context, when health financing strategies are also being drafted, as I mentioned also before, there's really three key components um, which are quite essential, which is really the revenue raising function, the pooling, and the purchasing. So any intervention that you look at really has this in the kind of the core of the intervention, that these aspects are taken care of. So where does the money actually come from? Is it tax sources? Is it coming through voluntary contributions, etc.? There are many different sources. So how are these raised? And then the entity which really pools these funds together and then takes over this kind of purchasing function. So purchases services from the healthcare provider. And of course, then these similar final coverage goals, which then are to be achieved around utilization, financial protection, and quality again. So going very concretely now into a particular context. So I take here a context of Tanzania, where I try to discuss different forms of health financing mechanisms. So this particular diagram is again a WHO diagram, which they discuss quite a lot, and it helps understand a bit this kind of flow of common revenue flows from source to pooling entities. So essentially where the money is coming from. So as you see here, it's clearly kind of black and blue public side, public funds, which are coming in different ways, marked, earmarked, tax subsidies, or private forms. And this is where also this out-of-pocket expenditure comes in. These, as I said before, these are at the point of care. So these can be in form of formal fees, informal user fees, or also co-payments. So part of the payments which are paid, which are shared by an individual. And now going into really specific examples in Tanzania. So for example, there is the National Health Insurance Fund, which is a autonomous, semi-autonomous public agency, which is targeting primarily the so-called formal sector. So looking at all employers, it's mandatory for them to make sure that all their employees are part of this program. Deductions are made based on their salaries, then passed on to the National Health Insurance Fund. And then the health insurance, NHIF basically provides the coverage, which means certain empaneled health facilities, these personnel can then go there and get free of care services, which are then paid by the insurance fund. And it's a similar logic also then with the community health funds. And in this case, it's at the regional government authorities have set up these, but in this case, focusing primarily at the so-called informal sector. So those who are not covered by formal sector employment. And this is then on a voluntary nature. So you have people who are offered a particular product, and it's their choice whether they wish to enroll or not. The same way, there's lots of for-profit insurers, so-called commercial insurers. They are local ones, Tanzanian ones, or there are local ones or regional ones, which are also offering similar insurance products, as well not-for-profit insurers like church-based entities or charitable health facilities or so. And at the same time, NGOs, savings group, etc., coming together, forming community-based health insurances. So these different forms. And also to add to that, there's also the so-called voucher programs. I just mentioned it here because in Tanzania, it's interestingly being now integrated into the insurance form where it's offered as an additional product. So it's targeting specifically pregnant women, but then offered as an additional top-up insurance product. So the idea with this was really to say there's quite a gambit of different forms of health insurance schemes. There are other forms as well. There's whether it's user fee, there's also performance-based financing. And all of these have similar or in some cases maybe very specific differences in terms of how they operate. And in Tanzania, and not just in Tanzania, but a lot of other LMIC contexts as well, there's quite a lot this move towards kind of more unified form, sort of a single national insurer or so, where the idea being really to bring the pooling function, the purchasing function really together, so that there's a stronger say and better say on behalf of people where services, healthcare services can be basically purchased. So this is really just to give you an idea of the different context, but perhaps you also have within your context something similar. And at this point, maybe I just stop briefly and Cha, are there any questions at all at this point, or shall we move on to the breakout sessions?
I think, Sir Siddharth, we can move on to the following part because there's no question yet.
All right. As I said, please do any questions that you might have, just type it into the chat. And then in that case, we move to the so-called reflection round. What we will now do is split you up into smaller groups and then give you around about 8 minutes or so, and then you will be brought back to the main session. So this will all happen virtually. And what we would request you to do in that time is really to think about the different financing mechanisms that you have in your respective country context, similar to the examples that I gave, for example, in Tanzania. And what I would request is really think about each of these mechanisms and try to reflect on this explanation, this kind of diagram, keeping this in mind, think about the revenue sources, the organizational type and how they function. So really around who pays, how does it function, what are the processes that are applied. You've probably all had your own different experiences within your healthcare system with these different mechanisms. So just try to reflect on how it functions. And in the next block, we will discuss health insurance processes specifically. And my hope would be that your reflection should allow you to then relate to your respective context, relate whatever you thought there to what I'm talking about, and perhaps you find some similarities, maybe even beyond health insurance. And once again, if you have any questions, then please type them in the chat. So Cha, please go ahead. Let's split everyone into the breakout rooms.
All right, sir.
All right, I think everyone's back now. Let's move on. I'm sorry, I think we were hoping to have smaller rooms, and the breakout rooms, they seem to be a bit bigger. We are also new to this, so sorry about that. And I hope at least I could only be part of one group. I hope that there were also discussion in the others, but we'll try to improve on this in subsequent times. But I hope at least you had some kind of reflection and thinking back on the kind of different financing mechanism. At least in my group, we were talking about different mechanisms which are there: Phil Health, private insurance, user fee forms, etc. But the idea was really to now talk about what happens within those systems. So here I wanted to now talk about really transactions within health insurance systems. So going more deeper into how these things function. So what you have is in any kind of health insurance system, really three key chunks or three blocks of actors. So you have the so-called purchaser, which is the side, the insurer who purchases services, as I said, with their own structure, personnel, etc., who are undertaking different transactions. You then have the healthcare provider side. So this is the health facilities. You have different types of providers. You have primary care, secondary care, tertiary care, dispensaries, health centers, referral hospitals, etc. So you have different types there who offer then different types of services and items. And at times these can also be at different prices. So you can have a public facility having a different price for the same service compared to a private facility. Then there are some kind of arrangements which are undertaken, some kind of contract which is then established between the purchaser and the healthcare provider, which defines what kind of services, what kind of will be covered and at what rates, prices that will be paid, what is excluded, etc. And all of these arrangements are then captured in some form of arrangement, and then certain transactions are undertaken based on that. You then have also with the client, the purchaser has some kind of arrangement. This is again turning into some kind of contract where it's then defined what kind of benefits are provided to an individual, what kind of amount contribution does the person has to do in order to get that kind of coverage, and all these conditions, etc., are also captured in some kind of an arrangement, and based on that, then certain transactions are being undertaken. You then have the client side, which then has their direct interaction with the healthcare provider. So the transactions which are taking place over there. So this is on a broader level, what kind of transactions are being undertaken. And then if I further delve into it and try to talk in a generic way, there can be four kind of broader categories. This is really the enrollment process. So that's whenever you're at the beginning, at a starting point, you decide to become part of a program and get some coverage, purchase it. So that's really the first time, the enrollment. Healthcare service utilization is, of course, when an individual has to then go and seek care. What kind of transactions might occur there? Then there is the claims processing, so submissions, scrutiny, and payment. So this is really about the patient has then gotten treatment, and then how does the health facility or how does the insurer basically make sure that the services are then paid for. And then lastly, the last category around renewal. So renewal would be a case where whenever you enroll into an insurance program, you do it for a specific period. So after that, if you decide to continue with it, that's essentially the term renewal. And modifications I mentioned here because it's something which is initiated by an individual. In some cases can also occur within an insurance system. So now, while I cover each of these processes, there'll be a short poll which will open and close and ask you whether in your context, so the reflection that you did, or I hope you were able to do some reflections, and that you really try to think of, let's say, the predominant health insurance scheme, and respond whether the respective process you can relate to it or not. If you feel that there are processes that are not covered, then do flag them, put them in the chat along with any other questions that you might have. So the first one is very broadly this so-called enrollment process, which I mentioned. And first I talk about a setting where it's a so-called voluntary scheme. So generally very popular within the informal sector. And here an insurer essentially needs to make an outreach and reach out to an individual, a household, group, to inform them, advise, and convince them. So some kind of outreach mechanism has to be created, which then reaches out. And then there's, of course, some information which needs to be captured. So there's information on each individual. There's also some kind of identifier which then needs to be captured so that subsequently the individual can be identified. And this can be in the form of photos, biometrics, whatever. And then, of course, a payment which has to be made. So if the price of that particular insurance product which is being offered, that has to be paid. Now, all of this information is captured, but at the same time, there is the need to provide some kind of identifier, some way in which this individual can be identified. This generally leads to some kind of ID card, which then, depending on the scheme, the level of digitization that they have applied, it could be something where information is locally stored on an ID card, so a biometric card or so, or that the information is not, the identifier is something simple, but the information is stored centrally somewhere, which is then retrieved later. And it's at this point to the client, when these ID cards are issued, there's also the need to provide some information. So there could be information related to a policy, what kind of coverage you have, what things are excluded, etc., which here then is also provided to the client. And of course, then all of this information then which is captured, as well as the money, it needs to somehow transfer back to the insurer, where the policy then can be activated. So that's essentially in a kind of very generic way, the range of different processes, the need for digitization or the data points. This is how they kind of come in within an enrollment process. The same way now, if you look at slight variation, so this is a different starting point where you might have an existing list. So say, for example, a company or so comes forward and says they would like to get all of their employees enrolled. So in this case, some information is already coming through to the insurer from a different point. Perhaps the money is also then being paid, and this comes through as well. Then needs to have some kind of outreach. They have to provide some information on what people have signed up for, perhaps their ID cards, etc., which need to be given. So that outreach mechanism then has to reach out to an individual, a family, household, or company employees, whatever, um, who then are then provided this information. It's sometimes possible that the information provided was only partial. So at this point, maybe some additional information is captured, or maybe biometric, for example, or a picture or so, depending on how the individual will be identified later. Perhaps that part of the information has to be captured at this point. And then, of course, once this is captured, needs to be sent back to sort of complete the whole process and then activate the coverage for that individual or set of individuals. Health service utilization. This is also, again, in a very generalized way. As I mentioned before, there's an identifier which is provided to a person who is then covered under an insurance program. So this individual essentially carries this identifier and goes to a healthcare facility, where at the point of reception or so, someone then needs to identify this person. So verification of the membership is done. So an individual is checked. It's the person's identity is checked, as well as eligibility. So what are they actually able to benefit at this health facility? And this again then depends on the level of digitization, what kind of identification mechanism that was being used. Um, and essentially, once the verification is done, if the individual is eligible, policy is activated, etc., it's the right individual, there's a valid card, then the person is, of course, treated as an insured person. There can also be cases where perhaps the card is invalid, not available or so, and there's absolutely no way to identify this individual. And in those scenarios, of course, then the person is treated as a non-insured client. So this is, again, in a very simplified way, what kind of processes are, what this process entails, and what kind of information points are there or needs are there for digital tools. In addition to this, it's also possible that perhaps there is some sort of pre-facility check where an individual wants to perhaps know what kind of benefits they have still remaining, what is the remaining eligibility, what kind of facilities they can go for, or perhaps the person just wants to see when the policy will be expired. So here again, some schemes can have processes which then require also some solution, some digitization solution to address these needs. So it could be, again, depending on the type of digital solution being used, that an identification is done at a designated point, an insurance office or so, or somewhere else, where there's a designated equipment or so, or that maybe the individual directly can undertake some kind of check, log in somewhere or retrieve some information from a central server or so uh, to understand what their eligibility is. After the individual has undertaken a treatment, or rather in the process, there's also, it's a bit mixed because it depends really on how the billing happens. So from an insurance scheme's perspective, really the part which is essential is at the point of payment. So when the billing happens, how is that dealt with? So you generally have an individual coming in, let's say in a bigger facility where there are different departments. So the doctor says, get this test done. The person goes there, comes back, the doctor looks at it and says, okay, based on that, these are the drugs provided to you. And in all of these transactions back and forth, finally, it's possible that there's then one point of billing. And this is, let's say, a case which is cashless. So the individual doesn't need to pay anything. Everything is covered by the insurer. So at the point of billing, the insurer essentially then submits everything. Sorry, the health facility, the billing point at the health facility then submits everything to the health insurer. Here, there can also be cases where certain schemes apply pre-authorization, which is a kind of pre-approval which is required before certain high-cost events. So it could be that an individual goes to the doctor flags this treatment has to be given, a surgery or so, which is high cost. And then at some point, before the treatment is actually given, pre-approval is requested and received from the side of the insurer. Sorry, from the side of the health facility. It could again be the billing point which makes this request, but the pre-authorization needs to come before the treatments are provided so that there's a guarantee that the payments will be made. It's also possible that in certain cases, this so-called billing department is not unified and it's maybe separate. It could be that you only go to a doctor, then to a different place to get a test, or to a different pharmacy, external pharmacy, or it could be that within a big hospital or so, you have different departments which are billing. So in this case, it's the same transaction, same treatment which the individual is happening, but different points which are then put together from different places into one place, which then relates to this one claim of the individual. And then obviously at the end, the eligibility, depending on whatever was done here, the eligibility of the individual has to be updated then. So if it's decentralized or centralized, accordingly, there's digitization needs are required then to address that. Same way, there could also be cases of so-called reimbursement, which is that an individual undertakes transactions in very similar ways, goes to different points, receives treatment, but at the end, the billing is done directly to the individual. So the individual is the one who's responsible for paying the health facility, and then the individual somehow has to submit to the insurer these bills and get a so-called reimbursement. And of course, then at the end, according to that, the remaining eligibility of the individual is then also updated. So what happens after that? So this is all about how an individual is at a facility and how the submission of claims comes. But then on the insurer side, it's never that all claims which come in are directly paid. There's always some amount of checks which are put into place, and they are then clustered into some checks which can be done automatically, and some checks which can be done, which need to be done manually. In addition, there are some schemes where also an additional process need comes in, where according to their business rules, maybe perhaps they want to have an additional process where they reopen the decision, the outcome of these checks which happened. Perhaps the check says rejected, but for some reason, some schemes say that they would want to open it up again and take it back again through the process for whatever reason. So this is an additional process which might then need. digitization. And then in the end, of course, once all of these processing checks, etc., are done, the final calculation of payments to be done, and then the direct payments to facilities are made. The last process around renewal, I mentioned here modification as well. So modification could be a case where, for example, a new child is born, someone is married into the family, or someone passed away, so someone has to be removed from the household unit. In all of these different cases, the initiation happens from the family side, and also some renewals where the family comes forward and says they would like to now extend their coverage within the insurance program. So here again, they have to somehow, they generally going through the outreach mechanism. So if it's a person who's appointed an agent or so, they are going to them. There's some money which is paid. There's some information which might be captured at that point. And in some schemes also, there might be needs of, again, depending on their business rules, they might issue new cards. So if that's the case, then perhaps these have to be captured or updated in some way, the new policy information, etc., that needs to be provided. And then, of course, whatever was collected needs to go back to the insurer, who would then update the system, whatever system they have, activate the coverage, and in case there are new cards to be issued, that they would issue them at this point. The same way, renewal can also be initiated from the other side. So from the side of the insurer, who then reaches out through their outreach mechanism, basically, and provides an information and says, go to these households and try to see if they would like to renew. So this information, maybe new ID cards, as mentioned before, these are all then taken through the outreach mechanisms provided to the family. It's possible, again, apart from money, of course, there might be more information which is then captured at that point, which is then, of course, has to somehow come back to the insurer and then activate the policy. So this is kind of in a kind of high level overview of these different processes where really digitization needs are there, and depending on the choices of the scheme, different solutions can come into play. So at this point, I will stop and maybe ask Cha in case there were any questions that we could answer. The idea here basically was that we talk about general procedures which have these kind of digitization needs, and then in subsequent sessions we'll try to specifically talk about how openIMIS then addresses these needs. And hopefully you were able to relate a little bit as well within your context, the different financing interventions that you are having interactions with. Sorry, go ahead.
Yes,
Is there any
Sir Siddharth.
questions?
So far, there's no question. I think our participants are still entering their queries, but there is a comment from Dr. Hasita from Sri Lanka. Doctor says that the country provides free health coverage to all the citizens through public health sector. When it comes to private sector, my understanding is that the enrollment process is a bit different. The enrollment happens in opt-in basis. When an individual wills to get insured, he or she reaches an insurance agent to get things done.
I mean, it's a very valid point, but I would, for example, I mean, just to relate to it in that context, when it's a kind of universal scheme, everyone is supposed to benefit. I guess, yes, there is probably in one way, no need in a way of having any kind of so-called enrollment process, because anyone who goes to the point of care is allowed and can access services. So yes, I mean, maybe in that case, it's difficult to relate to this kind of enrollment process. But at the same time, within the functioning of an insurance system, you will need some information then. So subsequently, for example, for a claims process, you do require elements like perhaps the age, the gender, etc. of an individual. So if the purchasing function is doing these kind of assessments, then the purchaser or the person who provides, who pays for these services, if it's not an input-based kind of system, it's based on some kind of outputs, and perhaps the output really is they would also like to see who was treated. In that case, this information would still be needed, because you would then submit a claim, the information comes in, and it needs to be then verified in some way. So there would be some form of kind of enrollment again, in that sense that you have a list of all the individuals who are then there in the system who are going and seeking care, and then doing kind of checks against that. Because also for fraud prevention, for fraud control, etc., you will have to have some form of checks in play. So I think there's some way to kind of relate to this.
Thank you,
Is
Sir
there,
Siddharth.
yeah?
I think there's a question from Dr. Nienke. My question is on CBHI. What are experiences with this type of insurance, positive and negative?
I guess the question is generally around then experience of CBHI as insurance forms. I mean, the view is not very divided, I think, out there. I think it's more on the decline right now, community-based health insurance schemes. Just in terms of reasons, I think it's a lot around the issue that they are small. They have smaller pools. And this is why when I mentioned before, a lot of countries, I think, are moving towards more consolidation rather than having more fragmented forms. And that's where I think the whole opinion comes in, to have more unified insurers, whether it's public insurer, kind of a single national insurer, or unified under a large government scheme which looks at formal sector or informal sector also. But generally speaking, I think the move is more towards unifying these pools to give a more stronger say for the purchasing function as well, of the insurer, which is very difficult with community-based insurance schemes, obviously, which have relatively smaller scale.
Thank you, Sir Siddharth. We now have a question from Dr. Ojulu. Dr. Ojulu is from Nigeria, where national health sector coverage is just 5%, covering mainly formal sector. However, the informal sector constitute a larger proportion of the population. Is it necessary to conduct poverty mapping before enrollment of the informal sector, since most of them are poor and cannot pay for themselves?
Yeah, I mean, this is also a big question. I mean, with in a lot of context with informal sector schemes, that's also one of the criticisms for them. So even if it's a government informal sector scheme, there's also sometimes criticism for that, that it's not able to reach out to everyone. The reason being, for a lot of people, still it's just not affordable. So you might have a Tanzania, for example, there is a, I would say, very, very cheap insurance product which is offered compared to what services are then covered under that. But even there's a large population which is unable to then enroll because they just can't afford it. And if you do go into further splits of the population and try to see, the so-called ability to pay from different groups, that varies quite a lot. So in the informal sector, especially if you're offering voluntary forms, this is always a question. And yeah, I mean, there's schemes also which come up with mixed ways of financing. I think in the Thai system as well, there's quite a lot of pooling from different sources, so different groups get certain subsidies, and perhaps that's probably a more decent way, more better approach of trying to find ways to accommodate different populations in it. But otherwise, that's always a big challenge, and also doing any kind of large scale mapping or so is always tricky and costly affair. So it's, yeah, it's a quite a tricky situation. And yeah, there's I don't know, I don't know of a perfect way, but there's different approaches. In some cases they've worked well, in some cases not.
Thank you, Sir Siddharth. Our next question is from Dr. Sablay. In the context of UHC, will a standardized health insurance system work for all socioeconomic classes?
I guess this relates a bit to the previous one as well. I doubt there will be any kind of system, because also what I mentioned before, with the broader health financing context, there is this whole aspect of equity as well. So if you want to create a system which is equitable, you will never be able to have, probably, especially when you have differences in your population, you'll never be able to have one standard approach which works for all. So there will be probably within even an health insurance system some form which is mandatory, in the if there is a voluntary side or not, even if, let's say for the informal sector, whether there is a voluntary form of insurance or non-voluntary form, one would have to find ways to also subsidize. And that might be part or um, full form of subsidy, but no, I doubt really there will be a standard approach that can be applied for the whole of your population, for all the different subsets.
Thank you, Sir Siddharth. All our participants, if you still have questions, please feel free to enter them in the chat box. Thank you.
Yeah, and I mean, just to say, since we have a bit of time, they had interactions personally, or maybe someone works in that field, whether it's insurance, voucher programs, or any kind of other programs. Um, but that these broader contexts, broader principles are really still cross-cutting. And when we then go deeper into processes where digitization needs are, there are also quite a lot of similarities. So the hope was that with this, we can have a kind of general discussion on what kind of mechanisms are in place, how does digitization really come in, and then we'll go specifically in the subsequent sessions on openIMIS and explaining how it then addresses these kind of processes. Thanks, Jai. That's it from my side. If there are no questions, or I think the invitations have the same invitation basically carried the registration for the subsequent sessions as well. And we hope that you have also registered for that. So it's the same time for the next 3 weeks, every Wednesday, right?
Yes, thank you, Sir Siddharth. We also have our chair, Dr. Bunchai Kijsanayoten, on the call. Maybe we can hear some words from him. Dr. Bunchai?
Hello, Dr. Sida and Salof. I think the session is really good. And it is, I think that open the new way that we do the workshop. I think it will be better. And actually, I have some reflection, but I think it might be good for our participant to think through this. And I think the way that you teach us the process first and then go to the application is really I mean, very good. For me, I think that each country have a different with different context. This is kind of the generic business model, and the way that how the country finance the health insurance or is I think vary from country to country, and it depends on the commitment of the government to do what they call the universal health coverage, who will bear the expense of the healthcare services. The insurance system is one that we share the resources and the revenue that come to that the fund is maybe different from country to country. In Thailand, we have 3 major health insurance, and we say that we are universal healthcare coverage. It means that all Thai citizens will be enrolled in one of the 3, and all the 3 have a different way to get the money into their fund. But I think the way that Dr. Sita explained, I think is very good and understandable. That is what my comment on the session. I think this is very good. I would recommend that the participant should download a slide and then go through that and think, compare and contrast between the generic business model and the sample of the Tanzania that Dr. Sita give in the presentation with our country. I mean, for each country, and then you will be more understand. I think the breakout session that have everyone think through is good, but maybe because of the session, this is the first one and it's very it's only 8 minutes. People may be not able to think through that, but I think the slide that you provide is really good. If we go through that again and then think about the process and how that you elaborate, that would help everyone to understand their health financing and health insurance, universal health care coverage in each country. And this will lead to how we can get the information and how the openIMIS will be help us to get the information to do all of the process. So if they don't have any question, then I thank you very much, Dr. Sita and Salov and GIZ group that provide us the AHIN, our community, to learn these very very important and very useful information and network and application. Thank you and good night.
Thank you, Dr. Bunchai. Thank you, everyone.
Thank you, Dr. Bunchai.
Thank you everyone. Bye bye.